Hi, welcome back. I'm Anna. I'm a clinical psychology doctoral candidate. In case you don't know me, on this channel we talk about real-life applications to psychology, and today we're talking about basically a guide to all of the anxiety disorders in the DSM-5. This is the diagnostic tool that we as therapists use to diagnose people with mental disorders, and it's really where all of the anxiety disorders and all of the other types of disorders as well are located, and so I think it's important to distribute that information to the general population so that you know what is out there and what the symptoms are and what our understanding is of why these things develop. I do want to mention, please don't self-diagnose. Please do not use this video as a tool to pinpoint what you think you have and then run with it. I think that's a major issue going on with the internet these days, is self-diagnosing and diagnosing other people with things that you're not qualified to diagnose them. It literally takes years for a professional to cultivate the skill of figuring out whether or not someone meets the criteria for a disorder, and if so, which disorder. And so this is more just a psychoeducational tool, a jumping off point. If you relate to any of these symptoms and you have the ability to, please by all means seek out a therapist who can provide you with quality information on whether that's true for you. Before we get into it, just a little bit of an overview on anxiety disorders. Generally speaking, they're characterized by excessive fear and anxiety, as well as a number of behavioral responses in reaction to that fear and anxiety. So fear is an emotion that you experience in response to an imminent threat, like a bear walking up to you. And anxiety is fear to an anticipated or a perceived threat that's not necessarily quite threatening your life, like anxiety about a test that's not necessarily putting you in imminent danger. There are a few things that are common criteria for pretty much all of the following disorders. The fear, anxiety, or avoidance that is experienced in the following disorders tends to be persistent. Usually it has to last at least 6 months. The disturbance has to cause clinically elevated distress. So something that a clinician would say, this is above what we would consider normative. This is something where it reaches the level of pathological, meaning having an illness, and or impairment in functioning in regards to social, academic, professional, or other types of functioning. So it interferes with your ability to function in day-to-day life in, various areas of your life. The disturbance also cannot be better explained by another mental disorder, a health problem, substance abuse, or something of the sort. So starting with separation anxiety disorder, this is one that we typically see in children, and the symptoms are recurrent and excessive distress when anticipating or experiencing separation from home or from a major attachment figure like a parent or a partner. Persistent and excessive worry about losing a major attachment figure or possible harm befalling them. Anxiety about something bad happening, like getting lost or kidnapped or in an accident that would cause separation from a major attachment figure. Persistent reluctance or refusal to go out or to go away from home due to fear of separation. Fear of being alone without major attachment figures present. Repeated nightmares involving the theme of separation, and repeated complaints of somatic symptoms when major attachment figures may be separated from you. So like saying, my tummy hurts, my head hurts, when your mom is off to work. Like I said, it tends to be more common in kids. The prevalence there is 4%, whereas it's 1.6% in adolescents, and we estimate that in adults it's about 0.9 to 1.9%. Onset is usually in preschool. That makes sense. That's usually the age at which children start to go off to school, have to be separated from their major attachment figures who maybe they've never had to be separated from until now. So that's usually somewhat of a normative response around that age. Risk factors for separation anxiety disorder include life stress, particularly a recent loss or leaving your child at home or getting into a relationship or becoming a parent, things related to attachment particularly. I thought it was interesting that all of these risk factors kind of indicate loving people that you care about and not wanting to lose them, and going through transitional time periods where there might be some changes going on with your attachment figures. Other risk factors, it's 73% heritable, so genetics play a big role. And interestingly, enhanced sensitivity to respiratory stimulation using carbon dioxide enriched air as also a risk factor, as well as gender. It's a bit harder on girls. And there's selective mutism, which is also another one of these that we usually see in childhood. I'm just gonna read from the book because it's easier. The criteria here are consistent failure to speak in specific social situations in which there's an expectation that you will be speaking, despite being able to speak in other situations, so it's not necessarily a language or cognitive issue. The disturbance has to interfere with your educational or professional achievement or with social communication. It has to be for at least 1 month and not just the first month of school. It has to be not attributable to a lack of understanding the language that you're meant to be speaking. Selective mutism is basically when usually children, but sometimes adults, just refuse to speak in certain situations. It tends to be a pretty good predictor for future social anxiety. Not surprisingly, it's associated with shyness, social anxiety, social isolation and withdrawal, clinging behaviors, compulsive traits, negativism, temper tantrums, or mild oppositional behavior. That's when kids are kind of oppositional, don't want to do what they're told, and throw temper tantrums. It's actually pretty rare, 0.03 to 1% prevalence. It's more likely in young kids, particularly young kids who are neurotic, high in behavioral inhibition, which is when you are very good at stopping yourself from doing a behavior that you want to do, usually out of risk aversion or fear of consequences. Another risk factor is parental history of shyness, social isolation, social anxiety, subtle receptive language difficulties, over-controlling or protective parents, genetics, and coming from an immigrant family. Actually, when I first moved to the US from Romania, I had a little bit of selective mutism because I didn't speak the language very well and I am very shy. And so there were some situations where I just refused to even tell people my name. Then there are specific phobias. These could be about animals, like fear of spiders or dogs or cockroaches, fear of natural environments like heights, storms, water, blood injection injury phobias. These are related to either seeing blood, having injections, or having injuries that usually cause blood. Or they could be situational, like being in airplanes, elevators, and closed spaces, or other, like loud sounds or clowns or something of the sort. For specific phobias, you have to have marked fear or anxiety about a specific object or situation, some of the ones I just mentioned. It has to almost always provoke immediate fear or anxiety. It has to be actively avoided or endured with very high intense distress or fear and anxiety. Fear or anxiety has to be out of proportion to the actual danger that is posed by the situation. If you might be afraid of airplanes, there's like a chance of 1 in 5 million to actually die because of an airplane crash. The average person with a specific phobia has about 3 phobias, so it's terribly common to have more than one. Over 75% of people who do have a phobia have more than one. And it's actually a pretty high prevalence, like 7 to 9% of the general population has a specific phobia, which makes sense. There are a lot of people that are scared of like bees, spiders, all that stuff. It's associated with increased physiological arousal, so your autonomic nervous system getting heightened in anticipation of or during exposure to the object that causes you fear. So it's a very bodily, very physiological response that you're having in those moments. It sometimes develops after a traumatic event, like if you are attacked by a dog. Not uncommon to be fearful of dogs in that situation, although it is rare. Observing others going through a traumatic event or having an unexpected panic attack in the feared situation. Like if you just have a random panic attack in an elevator, from that point forward, you might have a phobia of elevators. Usually onset is before age 10. That's usually when it develops, but not uncommon to develop it later as well. And the risk factors are neuroticism, like being prone to negative affect, behavioral inhibition again, parental overprotectiveness again, parental loss or separation, physical or intimate abuse, trauma related to the specific object, and genetics. Then there's social anxiety disorder, sometimes called social phobia. So this is kind of a disorder that is focused on one specific type of phobia, which is social interactions. You have to have marked fear or anxiety about one or more situations in which you are exposed to possible scrutiny by others, such as social interactions, like having a conversation, meeting new people, being observed, and performing in front of others, like giving a speech. You have to fear that you will act in a way or show anxiety symptoms that will be negatively evaluated, so fearing that other people are going to think that you suck, or other people are going to notice that you have social anxiety and therefore you suck. So fear of kind of being humiliated or embarrassed or rejected or offending other people. Social situations have to almost always provoke fear or anxiety, and they have to be avoided and endured with intense fear or anxiety. So usually people either try to completely avoid those situations, or if they have to go into them or they force themselves to go through them, it's very distressing for them. The fear or anxiety is out of proportion to the actual threat posed by the social situation. It's persistent, and all the other things that come with an anxiety disorder. There's also a performance-only specifier, so sometimes you might get diagnosed with social anxiety disorder performance only, which means you don't have social anxiety in most situations. It's just when it's related to performing, like public speaking, giving a presentation, speaking in front of larger crowds. It's a 7% prevalence, so pretty high, and it is higher in females. The median age at which it's developed is age 13, because that's usually when very stressful and humiliating things happen. If you think about like going into middle school, usually pretty traumatic for a lot of people. So that can be associated with stressful or humiliating experiences such as bullying, but sometimes it can also develop just more insidiously. Risk factors, again, behavioral inhibition, fear of negative evaluation, so being really scared of what other people are going to think of you and being worried that they're going to think negative things about you, childhood maltreatment or adversity, and a strong genetic influence. Also, the DSM-4 previously had a section, which is now just a little subsection of the social anxiety disorder in the DSM-5 called Taijin Kyofusho. I hope I'm pronouncing that correctly. Comes predominantly from Japan and Korea. It's kind of the more East Asian type of social anxiety where you are worried about being negatively evaluated by others, but it's more so fearing that you will make other people uncomfortable or offended rather than them simply thinking that you are not great, which reflects the more collectivistic values that can be in that part of the world. Then there's panic disorder. So a lot of people say I had a panic attack when they're referring to just feeling very distressed or feeling high amounts of anxiety. That's not quite what a panic attack is. Technically, it has a very specific definition, and that is recurrent unexpected panic attacks, which are a surge of intense fear or intense discomfort that reaches a peak within minutes and during which 4 or more of the following symptoms occur. So within minutes, remember, you can't have a panic attack that's like 45 minutes long. That's not something that is really possible because it's such a state of high physiological arousal that it's not possible. Like your body can't withstand that for more than a few minutes. So 4 of the following symptoms: palpitations, pounding heart or accelerated heart rate, that's all one thing, sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensations, paresthesias, which is numbness or tingling sensations, derealization or depersonalization. These are types of dissociation where you either feel like you're not within your own body or you feel like nothing around you is real. Fear of losing control or going crazy, and fear of dying. So if you have 4 of the following symptoms, then you could say that you're having a panic attack. But if you don't have all 4, it's still a very distressing situation. I don't want to invalidate that. It's just it wouldn't clinically count as a panic attack. So that's a panic attack, but to have panic disorder, it's more than just panic attacks. It's also that you have had at least 1 month where either you have very persistent concern or worry that you're going to have another panic attack and be worried about its consequences, or you have a significant maladaptive change in your behavior in response to panic attacks or in response to trying to avoid having a panic attack, like constantly monitoring your heart rate, trying to avoid certain situations where you fear you might have a panic attack, trying to sit next to the edge of a road so that you can get out if need be, things like that that reflect a fear that it's going to happen again. So that's really what panic disorder is. It's not just a panic attack, it's also very intense worry that more panic attacks are gonna happen. So panic disorder has about a 2 to 3% prevalence, and it's again higher in females. The age of onset is pretty late, usually 20 to 24, and the risk factors are pretty similar to everything we've been talking about. Neuroticism, anxiety sensitivity, which is a belief that the symptoms of anxiety are harmful, like if you experience symptoms of anxiety that you can't handle it. Worry of panic, sexual and physical childhood abuse, smoking, stressors in the months before a first panic attack, genetics, and asthma. Asthma is interesting. There is new research to suggest that actually people with asthma might be more prone to panic attacks because when you're having an asthma attack, it can be very similar to a panic attack, particularly the respiratory symptoms. And so what happens then is a lot of how we experience emotions depends on how we think about the bodily sensations that we're having. So if we have an asthma attack and we interpret that as anxiety, that can actually turn into a panic attack or actually worsen the initial asthma attack. Then there is agoraphobia, which is basically being afraid of being in either very large and cluttered spaces or very small spaces. When you think about agoraphobia, I kind of want you to think about a cat. House cats, indoor cats, get very scared of going outside. Most cats. If you have one of those that likes going on a leash and going on walks, I envy that. Tell me how you did it. But most house cats, after they've been indoors for a while, they get very agoraphobic, where they freak out, they're shaking, they're trembling, they're walking real close to the ground and the wall if you take them outside of their home. When we moved apartments, our cat bolted. She got as far as the elevator. Luckily, my partner was able to go get her from the elevator, but she was like, I'm out of here, I don't know the space. So that's kind of what agoraphobia is like. It's marked fear or anxiety about 2 or more of the following 5 situations: using public transportation, being in open spaces, being in enclosed spaces, standing in line or being in a crowd, or being outside of the home alone. It's essentially being worried that you're going to be in a place that's either hard to get out of, or hard to get out of if you're going to experience anxiety, or someplace where you're going to feel overwhelmed. And you have to fear or avoid these situations because of thoughts that escape might be difficult or help might not be available in the event that you're starting to develop panic-like symptoms. The agoraphobic situations have to almost always provoke fear or anxiety, and they have to be actively avoided and require the presence of a companion or be endured with intense fear or anxiety. The fear or anxiety has to be out of proportion to the actual danger posed by the agoraphobic situations and to the sociocultural context. So it's out of proportion to what danger you're actually in or to what is considered normal in your culture. Agoraphobia is a 1.7% prevalence and is 2 times more common in females. The average age of onset is 17 years old. And the risk factors are, again, behavioral inhibition, neuroticism, anxiety sensitivity, negative events in childhood, less warm or protective childhood homes. So with some of the anxiety disorders, we see overprotectiveness is a risk factor. For agoraphobia, it's less protective childhood homes, which makes sense because you're worried about not being safe or not feeling like you are secure in a certain context. That makes sense if you think about like childhood neglect. And its heritability is 61%. So the last major anxiety disorder within the anxiety disorder chapter of the DSM is generalized anxiety disorder, or GAD. When you think about GAD, I want you to think about primarily worrying. That's what characterizes this disorder, but of course to a clinically elevated level. So the symptoms here are excessive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities such as work or school performance. You'll often find with people with generalized anxiety disorder, the worry tends to jump from one thing to the next. So if you're worried about one thing, let's say you work on it in therapy, you move past it, then you might jump to something else. I've also noticed that oftentimes GAD tends to be misdiagnosed instead of obsessive compulsive disorder, which we'll get to in a second. And I think that's because OCD, which is classical obsession OCD, can sometimes look like generalized anxiety disorder in that those intrusive worries can sometimes be sort of like obsessions. Continuing with the criteria. The individual has to find it difficult to control the worry, and the anxiety and worry have to be associated with 3 or more of the following 6 symptoms: restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. The prevalence in kids is 0.9%, in adults it's 2.9%, and it's 2 times higher in females. The median age of onset is age 30, so pretty late, but most people who are diagnosed with GAD report that they've been anxious or nervous their whole lives. So there's a sense that it might go undiagnosed for a long time because it's so global, and worrying is something that to a degree everyone does, that people might not realize this is actually a disorder. It's associated with some muscle tension and soreness, and that definitely makes sense. Like if you're constantly worrying, constantly feeling keyed up, then that's going to reflect in your body. It's also often associated with somatic symptoms, exaggerated startle response. Again, going back to the cat metaphor, cats have a very exaggerated startle response. If you make a sound like peeling something off of a lid. They like freak out, they jump, they're very easily startled, and that's kind of what a startle response is like in humans as well. It's also associated with autonomic hyperarousal, what we were talking about in terms of your autonomic nervous system being very much on edge, very easily tipped. The risk factors are behavioral inhibition, neuroticism, harm avoidance, childhood adversity, parental overprotection, and genetics. Then there are some less clinically seen anxiety disorders, such as substance or medication-induced anxiety disorders, and this can be induced by alcohol, caffeine, cannabis, phencyclidine, hallucinogens, inhalants, opioids, sedatives, hypnotics or anxiolytics, amphetamines or other stimulants, cocaine, or other substances. It can also be due to a medical condition, like if you're diagnosed with terminal cancer, it stands to reason you're going to be feeling anxious about it, probably to a very elevated level, but that's likely because of the medical condition and the anxiety that you're having. And then there's other specified anxiety disorder, which is either limited symptom attacks, so if you're having panic attacks, but it doesn't have the full 4 criteria that you need. Generalized anxiety not occurring most days than not. Wind attacks, which are another one of those culturally contextualized anxiety disorders. This is actually a disorder that came from Cambodian refugees trying to conceptualize the somatic symptoms that they experienced because of distress. And ataque de nervios, which is an attack of nerves from people of Latino descent, is characterized by intense emotional upset, which can include acute anxiety and panic-like symptoms as well. Now, these are all the disorders that are in the anxiety disorders chapter of the DSM. But I want to mention, I wholeheartedly believe that obsessive compulsive disorder and other related disorders within the OCD chapter, such as body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling, excoriation, which is skin picking. I believe that all of these are anxiety disorders at their core. I think not many clinicians would disagree with that. There's a very obsessive compulsive nature to some types of anxiety disorders, and obsessive compulsive disorders certainly are characterized by a great deal of anxiety. So I would really put those under the same category, but technically they're not, and that's a whole nother video for another day. I would also put eating disorders under anxiety disorders, and this is a little bit more fringe, I think, but I personally would put most eating disorders under the obsessive compulsive disorder chapter as well, because I think there's an extremely obsessive and compulsive nature to them, particularly anorexia nervosa, binge eating disorder, and bulimia. And just to tell you a little bit about what's considered the golden standard treatment for anxiety disorders, usually it's cognitive behavioral therapy. Some people will disagree with me, some people have different theoretical orientations. I'm sure it still helps with some of these disorders. CBT is the one that I personally operate quite a bit from, and it has been very evidence-based by the literature. So it can include things like exposure therapy, so exposing yourself to things that make you scared socially or to your phobia. Or for panic disorder, it's a type of exposure therapy called interoceptive exposure, which is where you're inducing symptoms of panic attacks at increasing levels until you realize that it's not actually going to cause the end of the world, or it's not going to necessarily induce a panic attack, and that it's okay to have symptoms of panic. There's also cognitive restructuring, or things like DBT or ACT can be helpful with the more cognitive portion of some of these anxiety disorders, like what you think about, beliefs that you hold, some of the cognitive errors that you make, like catastrophizing or black and white thinking. Exposure and response prevention therapy is very much used for obsessive compulsive disorder or things that have an obsessive compulsive nature, such as eating disorders. Relaxation, grounding, and mindfulness skills can be very helpful for all anxiety disorders. And developing safe attachment, whether through your therapist, like having that solid therapeutic alliance, solid rapport, or through other people, because some of these things can have more of an attachment basis, like we saw with the agoraphobia, like parental neglect can be associated with that, separation anxiety, social anxiety, those can definitely have an attachment component as well. So those are some of the treatments for these anxiety disorders, by no means all of them, but some of the ones that I'm more familiar with. So I hope this was helpful for you, just to give you kind of a brief overview of what all of the anxiety disorders are. I hope that if you relate to this, you're able to seek out the professional treatment that you need. If you like this video, hit like, subscribe, hit the bell notification button. I put out 2 new videos every week, and I'll see you soon.